Welcome back, everyone. Today's explainer is a step-by-step masterclass on a truly fascinating and honestly often misunderstood clinical emergency, refeeding syndrome. I'm absolutely thrilled to guide you through the exact physiological story of how this all unfolds. We're going to break down the complex biological flowcharts and really get into those minute cellular details to understand exactly what goes wrong when a starving body is suddenly fed. So let's jump right in.
Now, to start off, we really have to look at our central premise. We typically think of food as inherently healing, right? But what if offering a starving patient a meal could actually trigger a deadly metabolic cascade? The absolute most crucial thing to grasp right out of the gate here is that it's not the food itself that's dangerous. Instead, it's the violent, abrupt physiological transition that sudden nutrition forces onto the body. It's literally a whiplash shift from tearing itself down to suddenly, frantically, trying to build itself back up. Here's our roadmap for this explainer. 1. The starvation response. 2. The metabolic switch. 3. Electrolyte and fluid shifts. 4. ATP depletion and organ failure. 5. Identifying high-risk patients. And finally 6. Prevention and safe management.
All right, Section 1. The starvation response, the baseline of depletion. Before we can really understand the crisis of refeeding, we first have to establish the incredibly fragile, heavily depleted baseline the body enters when dietary carbohydrates just disappear. Now, the starvation sequence is actually highly predictable. When food stops, blood glucose falls. That makes sense. This immediately triggers the pancreas to drop its insulin secretion and ramp up glucagon. Within just 24 hours, hepatic glycogen stores are completely exhausted. Fast forward a few days and lipolysis takes over, meaning fatty acids become the major fuel source. And then, over prolonged starvation, the body has literally no choice but to start breaking down skeletal muscle protein for gluconeogenesis just to keep the essential organs running. It's in full survival mode.
But here is a critical clinical trap hidden right within this phase. You might pull a routine blood panel on a starved patient and see what looks like perfectly normal serum electrolyte levels. But guys, this is deceptive normalcy. Because the overall cellular metabolism has slowed way down, serum phosphate, potassium, and magnesium can appear completely fine in the blood, while the total body store, meaning what's actually inside the cells, is dangerously empty. You simply cannot judge this book by its cover.
Moving to Section 2. The metabolic switch, the critical inflection point.
This right here is the catalyst of the entire syndrome. It's the exact critical inflection point when our starved patient receives their very first meal. Okay, let's dive into this. I want you to picture the sudden introduction of carbohydrates into this incredibly fragile catabolic system we just talked about. The patient has been surviving on fat and muscle breakdown, and then suddenly, boom, the intestines absorb a massive surge of carbohydrates. So what actually happens?
Well, it brilliantly illustrates the core tension of this two-state system. In starvation, remember, we have low insulin and high glucagon. But the exact moment carbohydrates hit the bloodstream, blood glucose rises and the pancreas aggressively secretes insulin. So the absolute crucial point is this. The carbohydrate itself isn't the primary weapon here. It's that massive carbohydrate-induced insulin secretion that literally slams the body from a catabolic state directly into an anabolic state.
That brings us to Section 3, electrolyte and fluid shifts. The intracellular rush.
To really grasp the danger of that insulin spike, we need to shift our focus down to the microscopic cellular level to watch this intracellular rush. Here's the exact sequence. Feeding begins, glucose rises, and insulin surges. Now think of insulin acting like a bouncer, aggressively throwing open the doors to the body's cells. Glucose floods in. But keep in mind, insulin doesn't destroy the electrolytes in the blood, it simply forces them to rapidly redistribute. Because this new anabolic state requires massive amounts of raw materials, phosphate, potassium, and magnesium are dragged right out of the bloodstream and forced into the metabolically active cells right alongside the glucose. Zooming in on these specific cellular mechanisms, we see insulin activating the Na+, K+ ATPase pump, which rapidly drives potassium into the cells, causing sudden hypokalemia. Magnesium shifts inside for ATP reactions, leading to hypomagnesemia. And over at the kidneys, insulin promotes renal sodium retention. And you know the rule, water always follows sodium. The crazy part? This cascade isn't happening over weeks. It can happen in mere hours. Now, zooming back out to the clinical consequences, that drop in magnesium can trigger fatal torsade de Pointes arrhythmias, while the sodium retention rapidly causes pulmonary edema and fluid overload. It's a perfect storm.
All right, Section 4, ATP depletion and organ failure, the hallmark consequence. This is where we really need to shift our focus to the most critical molecule in this entire cascade. Let's be explicitly clear here. Hypophosphatemia is the hallmark of refeeding syndrome. When all that phosphate rushes out of the blood and into the cells to support this sudden burst of anabolism, the already depleted total body phosphate stores hit absolute rock bottom. And without intracellular phosphate, the mitochondria simply cannot produce ATP. You effectively shut down the primary energy supply to every single organ in the entire body.
Let's connect that microscopic lack of ATP directly to macrosystemic failures. Notice how the organs with continuous high energy demands are the ones that fail first. Without ATP, the heart muscle just cannot contract, leading straight to acute cardiac failure. The diaphragm weakens, causing respiratory failure. In the blood, a lack of phosphate reduces 2,3-BPG. This means hemoglobin won't release oxygen to the tissues, causing severe hypoxia. And in the skeletal muscle, those cellular membranes literally become unstable and break open, resulting in rhabdomyolysis. We're talking about a catastrophic multi-system collapse.
On to Section 5, identifying high-risk patients, recognizing vulnerability before feeding.
So now let's transition from pure pathophysiology to clinical application on the ward. How do we actually recognize this profound vulnerability before we ever offer a meal? I want you to mentally screenshot this exact data right now. These are the major risk criteria. We're looking at a BMI under 16, unintentional weight loss greater than 15% in just 3 to 6 months, little to no nutritional intake for more than 10 days, or a low baseline of serum electrolytes before you even begin feeding. And here's the kicker. Possessing just a single one of these major criteria confirms the patient is at high risk, just one.
Now, we also have additional risk factors. If a patient has any two of these, they are also considered highly vulnerable. Let's look closely at a history of alcohol misuse. This is particularly dangerous. Not only do these patients already suffer from severe nutritional and electrolyte depletion, but alcohol dependence adds a severe thiamine deficiency into the mix. And since thiamine is absolutely essential for carbohydrate metabolism, their ability to safely process a new meal is already deeply crippled before you even start.
Which brings us to Section 6, Prevention and Safe Management, the clinical solution. Okay, we're in the final phase. How do we reverse engineer this biological thriller to safely rehabilitate the patient without causing them harm? Well, here is your life-saving treatment pathway. Step 1, identify the high-risk patients. Step 2, aggressively check and correct those baseline electrolytes. Step 3, administer thiamine before you ever introduce carbohydrates, ensuring they can actually be metabolized safely. And Step 4, guys, this is vital. Begin feeding at 50% or less of their calculated nutritional requirements. Starting this low intentionally prevents that massive deadly insulin surge we talked about, allowing you to gradually escalate their nutrition while monitoring them every single day.
We're going to conclude this explainer with a really powerful take-home message. Refeeding syndrome is fundamentally a disorder of physiology rather than nutrition alone. By anticipating that hidden intracellular depletion and truly understanding the domino effects triggered by insulin, we can save lives through gradual, meticulously monitored care. It's that simple. I'll leave you with this final thought to consider. If a simple, sudden rush of insulin can completely unravel the body's entire physiological equilibrium in a matter of hours, what other hidden metabolic traps are we walking past on the wards every single day?